Well, thank you very much, James. Thank you very much for that kind introduction. And thank you, Michael from the Fatty Liver Alliance, Marco, collaborator abroad in Europe from ELPA, and everyone for the invitation to say a few words about the human and economic burden of MASLD and MASH. As Dr. Krog mentioned, we will be using that interchangeably with NAFLD and NASH. Even when there's older studies, it is now applicable because, as Dr. Krog showed, the overlap between these two populations is almost 100%. And as Dr. Ranella will speak about soon, we've gone through this long process to change the nomenclature. So I'm just going to be very brief so that all of the primary care physicians and other people in the audience understand that this was a focus on avoiding stigma, but also making the name more accurate, more precise, and with clear defining characteristics that we think will also be of great benefit to everyone in primary care, as I'll go on to explain, when you're looking at patients at risk, when you're diagnosing patients, or even when you're following up patients, because the vast majority of patients for quite some time will remain in the care of primary care physicians. So the diagnostic criteria that Dr. Krog briefly mentioned include steatosis or undergoing evaluation for suspected steatosis, but also having diabetes or prediabetes, central obesity, hypertension, or metabolic dyslipidemia. So you are seeing many patients that are going to fit this category and who are either at risk or already have MASLD and likely have undiagnosed MASLD. And that's what I think we need to change so that we can risk stratify the most serious cases to specialist care, and everyone else will stay in primary care. So that means we need to go beyond a focus on these specialties. I am not a hepatologist or gastroenterologist. I work in public health, and we need to think about the public health perspective. That means that most patients will be seen outside of the specialists until, and hopefully they won't advance, but we need to be thinking about how these specialists can engage with all of you and this whole range of other healthcare professionals, be it nutritionists, cardiologists, obesity medicine, behavioral psychology, because so many patients are also suffering from mental health issues. MASLD as was shown, affects an estimated 38% of all adults around the world with great variation. And it's really being driven by, the massive growth and high prevalence of obesity, as you see here. So many countries with greater than 30% obesity, some now approaching over 40% overweight or obesity among the adult population. That results in more MASLD. And as Dr. Krog mentioned, one place we're going to find a high prevalence of MASLD is in those living with type 2 diabetes. Around 2/3 will have MASLD, over a third will have MASH, around 17% will have advanced fibrosis. Just today, there was a publication in Lancet GastroHep calling for a liver health check for everyone with type 2 diabetes. And there'll be other populations that should also have such a liver health check, for example, everyone with obesity. Now, some of the high-risk groups and factors, they were mentioned briefly. I mean, you will see people with one and likely many of these factors for MASLD and MASLD MASH progression. So I'm sure everyone in the audience sees people with lifestyle factors such as sedentary lifestyle and poor diet, which are major contributors to MASLD, overweight, obviously older age, alcohol, diabetes. And when you start to combine 2 or 3 or 4 or 5 of these factors, it's very likely that that person is going to have MASLD and even possibly MASH. So what are the implications for management and care pathway? I'll just say very briefly, for everyone with MASLD, they'll need a minimal metabolic assessment that'll include hyperglycemia, dyslipidemia, hypertension, and obesity, and a further workup for cardiovascular disease and other conditions as appropriate. But for everyone who's obese or has diabetes, they'll need a workup for MASLD and liver fibrosis, and if cirrhosis, will also benefit from screening for liver cancer. And when you hear that there's no treatments for MASLD, well, there are treatments that benefit both MASLD and concurrent metabolic conditions. While it's true we don't yet, although we're close, we think, have a specific MASH drug, lifestyle interventions, which many of you are already prescribing for your patients for other reasons, will be beneficial for MASLD, metabolic drugs, and in some cases, bariatric surgery. I'm of the belief that when people are aware that they have MASLD, even at a very low fibrosis stage, it's worth their knowing, because it's one more reason for them to want to try to adhere to those kinds of lifestyle interventions that are challenging for many people in the longer run. And when we think about that, we need to think about nutrition and social nutrition and the environment that patients are living in. So this is a very busy slide, but I just wanted to mention a couple of important concepts. I think many of you will be familiar with social nutrition. It takes into the equation the commercial determinants, cultural aspects, social support, socioeconomic status. So it's not enough to tell people, go home and improve your diet, or here's where you can find healthy recipes. We need to know what challenges they're going to face. If we don't address those, it's going to be very difficult to have people improve their diet, which is fundamental to addressing MASLD, MASH, or preventing both of them. So we have the opportunity for social prescribing, where those of a certain socioeconomic status might be linked to community-based organizations that can help with food or address food insecurity. And in general, we just need to be thinking about the what, when, how, and why individuals eat. I know most primary care physicians have very little time with their patients, but this will be beneficial, not just for liver health, but for cardiovascular health, and for their overall health or metabolic health more generally. So it's worth taking the time to understand the patients and see what opportunities there are in the community to help people adhere to the lifestyle changes that you're prescribing to each patient. So all of this means that we really need a paradigm shift to more patient-centered care. We need to go from a disease-centered care, so it's not just about MASLD and MASH or cardiovascular disease or obesity, but to look at all of the comorbidities and to look at individuals' health-related quality of life as well. So we want to be treating the person and not just the disease. So I think optimal care, as mentioned, will mean that primary care providers play a central role. There'll be initial risk stratification, often with FIB4, that will be discussed later, but that's a very simple test. It's a simple calculator. It's free online. And if you're ordering liver function tests and you know the age of the patient, you can calculate it, or you can request it to be calculated. There'll be important weight management issues, health psychology issues, and then cardiology and advanced lipid management, which will go to specialists when you're risk stratifying and sending those that are above a certain cutoff for their FIB4 for a further workup to see if they have fibrosis and if that fibrosis is attributable to MASLD and MASH. It's important that our models of care are comprehensive, that there's good referral systems, that there's an understanding in hepatology of what can be done in primary care, and vice versa, what can be done in hepatology. Hepatologists and other specialists will not be able to see everyone with MASLD, so it will be important for primary care physicians, and that's why I think this summit is so important, to really understand the basics of MASLD and MASH and what you can do. And first and foremost, what you can do is use FIB4 or another non-invasive test, understand what those basic cutoffs are, and if you should be referring for specialist care or not. The social determinants of health play an important role in patients' healthcare seeking behavior. Will they return for a visit? Will they adhere to the lifestyle treatments that you're prescribing for them? We know from a systematic review that low socioeconomic status is associated with a higher NAFLD prevalence, a higher NASH or MASH prevalence and higher liver cancer rates. And that's why I think concepts like social nutrition, social prescribing, and understanding our patients and not just their disease are so important. And primary care physicians, family doctors are those who best know the patients out in the community. You also understand issues related to stigma. There can be public stigma related to obesity, again, a leading risk factor for MASLD and MASH. There can be structural stigma, which we've been trying to address through the nomenclature change to metabolic dysfunction-associated steatotic liver disease. Quite a mouthful. I'm not sure how many other diseases have that many syllables, but you can just say MASLD and MASH, and soon everyone will know what you're talking about. But there's also stigma in health settings. So we need to be careful and think about using person-centered language, people-first terminology, and thinking about how our language might be stigmatizing or even lead to discrimination, what you're putting in the charts, what's going forward with the patients, because that can contribute to self-stigma. This is again from the EASL Lancet Liver Commission that Dr. Krog mentioned, and that can result in care avoidance and delayed care, increases in unhealthy behaviors and advanced liver disease, and ultimately increase health and social inequalities and inequities. So how we engage with patients, how we refer to them and the diseases they may be living with is very, very important. I'll start to wrap up and just say that, the field has gone through a lot of changes the last year. We have a new name, MASLD and MASH, under the banner of steatotic liver disease. We have a new disease group, MASLD, combining the metabolic with the alcohol and high prevalence there. But we've also published a series of research and action priorities because there is a lot we can do, even if we don't have a MASH-specific drug. We can be thinking about our models of care, how to increase education and awareness like we're doing on this seminar, the kinds of leadership and policies we need. We need WHO in Canada, leading agencies to be and ministries to be addressing liver disease as a public health issue, as a public health threat. We need to better characterize both the human and economic burden through investment frameworks, through stronger prevalence studies that also go one level below the general population and start to understand the prevalence like we've done in obesity and diabetes type 2 within other disease or therapeutic areas. Always treatment and care. And again, we expect 2024 and 2025 to be exciting years with drugs going to approval and hopefully being approved for MASH. But again, there are things you can be doing now. And as always, and that's why it's great to have Fatty Liver Alliance and ELPA collaborating, the European Liver Patients Association, we need to be listening to the patients and understanding both patient and community perspectives on this disease. So in conclusion, this is about growing the community of practice. We are not, I don't have a pointer like Dr. Krog did, but if you look in the upper left, this is not a disease that's going to be resolved within hepatology or gastroenterology, or even if we add in endocrinology. Primary care will play an important role, but it's also not going to be resolved just among healthcare providers. We need associated NGOs and community-based organizations. We need industry, not just those involved in diagnostics and developing treatments, but also those in digital health who can help us with artificial intelligence and other tools to be able to better identify those at risk or those most likely to have MASLD and MASH. And then, as always, the research community needs to go beyond the clinical research and also look at public health and global health issues so that MASLD and MASH don't continue to be left behind, but are understood to be integral to achieving the Sustainable Development Goals and so many other health and development goals where liver health is often not a part of that particular agenda. Some of you on the call might have been involved, but over 500 people from around the world, many in Canada, have been a part of these processes to change the nomenclature, to develop the research and action priorities, and to have many discussions over the years. And we're really grateful for the time you've contributed to that. So thank you again to the Fatty Liver Alliance for allowing us to say a few words about the human and economic burden of MASLD and MASH.